Look at the heavy, asymmetric drop in this toddler's stride. It is a highly visible, debilitating mechanical failure. Yet in nearly every case, this pathology begins entirely invisibly at birth, presenting only as a silent, painless joint instability. If that initial instability goes undetected, the joint mechanics rapidly deteriorate. Over time, the abnormal friction destroys the cartilage, guaranteeing early osteoarthritis, chronic pain, and a permanent discrepancy in leg length. We refer to this condition as developmental dysplasia of the hip, or DDH. For decades, it was known as congenital hip dysplasia, but the medical community has explicitly shifted away from that terminology. The word congenital implies a static, fixed anatomical defect that a child is simply born with. The pathology here is entirely different. It is an active, progressive deformation of the joint that actively worsens throughout early infancy. Because DDH is a moving target, a progressive anatomical failure tied to the child's rapid growth, diagnosing it requires us to constantly adapt our clinical toolkit to match the changing biology of the infant. To understand how the joint deforms, we have to look at the baseline mechanics of a neonatal hip. At birth, the acetabulum, the socket of the pelvis, is mostly soft cartilage, and it requires continuous physical stimulation to grow correctly. This 3D model demonstrates that required stimulus. The constant, perfectly centered presence of the femoral head physically pushes against the surrounding tissue. That pressure signals the socket to grow deep and concave around the bone. The pathology of DDH begins when transient joint instability allows the femoral head to shift slightly off-center. Without that direct centered pressure, acetabular growth stalls. The socket remains dangerously shallow and flat while the rest of the pelvis expands. This creates a destructive mechanical feedback loop. A shallow socket cannot securely contain the femoral head, leading to even greater instability. Eventually, the femur escapes the joint entirely, sliding upward into a full subluxation. The initial instability triggering this cascade is almost always driven by high-yield environmental risk factors, specifically physical restrictions placed on the fetus in utero. Breech presentation and oligohydramnios, a lower than normal volume of amniotic fluid, are massive risk factors. Both conditions physically pin the fetal legs in abnormal positions, preventing the femoral head from seating properly into the socket before birth. Female sex and left hip dominance further compound the risk. The left hip is typically pressed tightly against the maternal spine. Additionally, female infants are uniquely susceptible to circulating maternal hormones that induce severe ligamentous laxity. When you combine the mechanical restriction of the intrauterine space with the hormonal softening of the joint ligaments, you create the exact structural instability required to kick off the degenerative feedback loop of DDH. Navigating this pathology requires dividing the infant's first year into distinct chronological diagnostic phases, beginning with the neonatal window from birth to 3 months of age. During these first 3 months, the infant's hip joint is defined by extreme capsular and soft tissue laxity. The ligaments are pliable and the bones are highly mobile. Because the joint is so loose, passive observation is useless. The diagnostic strategy must be active and provocative. We must manually apply force to determine if the joint can be pushed out of the socket or, if it is already out, whether it can be popped back in. The Barlow maneuver identifies an unstable hip. Adducting the femur with posterior pressure pushes the head out of the socket. The Ortolani maneuver tests if a dislocated hip is reducible. Abducting the femur and pulling anteriorly seats it back into position. A positive Ortolani test is defined by specific tactile feedback. The clinician must feel a distinct, palpable clunk as the head drops over the acetabular ridge. High-pitched benign soft tissue clicks are common and should not be mistaken for actual reduction. It is also worth noting that traditional tight swaddling, which binds the infant's legs into strict extension and adduction, mechanically mirrors a sustained Barlow maneuver. It continuously pushes the femoral head out of the socket, actively worsening the dysplasia. This high degree of tissue laxity dictates not only our physical exams, but also our imaging protocols for infants under 6 months of age. Ultrasound is the absolute gold standard imaging modality during this window. The infant's femoral head is still entirely cartilaginous. It lacks calcium, meaning it is completely invisible on a traditional X-ray. In this initial 0 to 3 month phase, The pliable nature of the infant's biology forces us to rely entirely on hands-on provocative maneuvers and soft tissue ultrasound to catch the instability before the joint permanently deforms. That diagnostic protocol completely breaks down as the infant crosses the 3-month mark, driven by a critical biological inflection point. As the effects of maternal hormones fade, the joint capsule and the surrounding ligaments rapidly lose their early laxity. The soft tissues tighten, securing the joint in whatever anatomical position it currently holds. The immediate clinical consequence of this tightening is that the Ortolani and Barlow maneuvers become physically impossible. You can no longer push the hip out, nor can you easily pull a dislocated hip back in. The clinician must completely abandon provocative testing. Instead, the diagnostic focus shifts entirely to identifying fixed observational physical signs of asymmetry. The first and most reliable of these fixed signs is a severe limitation in hip abduction on the affected side. The tightened soft tissues restrict the joint's lateral mobility. Secondary visual cues also emerge on the skin itself. As the dysplastic femur migrates upward, the soft tissues compress, creating distinct asymmetric thigh folds and uneven gluteal skin creases. To definitively confirm a unilateral dislocation in this older age group, we look for the Galeazzi sign. For the Galeazzi sign, the infant is supine with hips and knees flexed. A horizontal plane reveals the affected knee rests noticeably lower. Panning to the pelvis, the dislocated femoral head has nigrated superiorly, functionally shortening the leg and dragging the knee down. As the infant's connective tissues harden, the primary evidence of DDH transitions away from joint mobility. The pathology is now locked in place, revealing itself through fixed, visible anatomical asymmetry. At 6 months of age, the infant hits another major developmental milestone, one that forces a complete shift in our imaging strategy. The soft, cartilaginous femoral head finally begins to calcify. An ossific nucleus forms directly in the center of the cartilage, rapidly increasing the density of the bone. Because ultrasound cannot penetrate dense bone, it loses its diagnostic utility. Plain film antero-posterior X-rays now become the gold standard for evaluating the hip. On an X-ray, drawing the horizontal Hilgenreiner line and vertical Perkin lines creates a 4-quadrant grid. The ossified femoral head must reside within the inferomedial quadrant. Here, the healthy right hip is positioned correctly, while the dysplastic left hip has escaped superolaterally. These progressive anatomical principles, from early laxity to gradual ossification, directly dictate exactly how we approach clinical management. The core logic of DDH treatment is straightforward. The younger the infant, the more pliable the cartilage, and the higher the potential for the acetabular socket to successfully remodel its shape. For infants diagnosed under 6 months of age, the absolute first-line treatment is the application of a Pavlik harness. The biomechanics of the Pavlik harness are highly specific. As shown here, the straps force the infant's hips into strict, constant flexion and abduction. Holding the legs upward and outward artificially drives the femoral head deep into the center of the socket. The harness cures the dysplasia by artificially recreating the natural mechanical feedback loop. By locking the femur in the correct position, it forces the bone to stimulate the cartilage, prompting a deep, stable socket to form well before the pelvis permanently ossifies. If the diagnosis is delayed past 6 months, or if the Pavlik harness fails to secure the joint, treatment must immediately escalate. Clinicians will move to closed or open surgical reductions under anesthesia and often perform bone osteotomies to physically realign the acetabular coverage. However, these aggressive interventions carry severe risks. The most critical iatrogenic complication associated with DDH treatment is avascular necrosis of the femoral head. The blood vessels supplying the infant femoral head are extremely fragile. Over-tightening a harness in extreme abduction or performing too aggressive a surgical reduction physically compresses these vessels. This chokes off the vascular supply, killing the growing bone. Conversely, doing nothing carries a much heavier penalty. This is the classic late-stage presentation of completely untreated bilateral DDH in an older, ambulatory child. The bilateral dislocation forces the pelvis to tilt, creating severe lumbar lordosis and a distinct swaying, waddling gait. This represents the end of the pathological timeline. A completely silent neonatal joint laxity goes missed, leading to a structural limb shortening, which guarantees premature joint destruction and eventual osteoarthritis. For clinical practice and board exams, mastering this timeline requires memorizing the chronological diagnostic rule. Rely on provocative testing and ultrasound before 6 months, and shift to observational signs and X-rays after 6 months. You must also recognize the classic demographic profile: a firstborn female with a history of breech presentation, presenting with isolated left hip instability, is the textbook standard for this condition. Developmental dysplasia of the hip is a mechanical problem with a highly time-sensitive mechanical solution. Understanding the progressive nature of the deformity ensures that early clinical vigilance translates directly into lifelong mobility for the child.